So my name is Connolly. I'm a GP with special interest based in Bradford, a special interest in women's health, I should say, based in Bradford. And I've done lots of work with Endometriosis UK to promote education around endometriosis. I'm just going to do a little bit of an introduction about primary care and endometriosis and the challenges that we face. We're then going to have, as I say, 3 expert speakers talking to us about how can we support endometriosis patients from a specialist point of view. We're going to have general pelvic pain management, and then we're going to have something on latest in endometriosis care so we can better advise our patients in primary care and support them as we always do. And then we're going to have a couple of cases, and finally we'll have the time for those questions that I know you will want to be asking. So endometriosis for us in primary care, we often we get slated because in theory we don't do very well. I'm going to show you 2 aspects from that. Firstly, this is an all-party parliamentary group report from 2020, and this was a survey of a significant number of patients and about how they felt their endometriosis impacted on them and the issues they had about getting the diagnosis for endometriosis and the care that they were offered and wanted. Endometriosis, the more work I've done on endometriosis over the last few years, the more I really recognise the impact it has on our population. It is so common. And some of you who are listening to this call will have endometriosis, or you'll have children with endometriosis, or you will certainly have cared for women with endometriosis. And the impact this has, particularly on younger women who are trying to get their education completed, trying to get their exams done, trying to get a good start in life, really sets them off quite badly, because every month they may have to be taking a few days off their education or their workplace. And period problems are always very difficult, aren't they? Because if somebody is off for longer, they have an operation, we can give them a fit note or give them time off and then go to their workplace or school and show a big scar or a report from the hospital. But every month, women with endometriosis will have to be taking a few days off, and then they get into a problem at their education provider or at the workplace. And this report had lots of different bits of the survey really showing the impact that endometriosis can have. Unfortunately, there's this still extended length of time to diagnosis. I mean, we can debate in primary care about how diagnosis is made, because we know that true diagnosis has to be by laparoscopy. But sometimes with a patient, after a discussion, we will make that diagnosis after a trial of treatment. And some women are very happy with that and don't want or need more input from specialists. But I'm sure we're going to hear more about that. But it's not just us in primary care. So this is a UK survey. I know this is an international call. But in the UK, it's not just in primary care who don't do as well as we could do, but there's also complaints about the time it takes to see the gynecologist and also A&E. So generally, we don't do well with endometriosis. And then there was a really interesting paper written by Sharon Dixon and crew, who are academic GPs based in Oxford. And this was written up in the British Journal of General Practice. And this was a survey of clinicians. So they interviewed a number of clinicians. Some had an interest in women's health, some didn't. They were all GPs all around the country. And they were looking at the concerns that GPs have about endometriosis and really sort of trying to explain why it is so complex. Many women will put up with symptoms for a long time. We know that we don't talk well about period problems, so many will delay their presentation to us. We also know that sometimes symptoms might be non-specific, or women may present them in a way that isn't very clear. Some of it is about the knowledge that we as clinicians have, but also if patients sometimes complain of vague symptoms, we need to be doing other tests first, because we always have to exclude those red flags before we can go down a certain pathway. Sometimes we trial treatments before referring on, and that adds extra time. Need to be making sure the patient is kept aware and they know what their options are. shared decision making. And many patients really enjoy, and we as clinicians enjoy, that continuity of holistic care, because endometriosis will come up again in different aspects of her reproductive life. And we'll hear from Karolina later on about the impact of the chronic pain. So we need to do better about endometriosis diagnosis, early recognition, getting treatments in, but actually it's not quite as clear cut for us in primary care as it might appear to be. And I just thought I'd share those two slides as a little bit of background information for you. So let's move on to the experts now. And I'll say we've got three brilliant expert speakers. So first of all, we're going to have Fevzi Shakir, who's going to talk to us about how we can support in primary care, in family doctors, how we can support our endometriosis patient. Now, Fevzi works at the Royal Free Hospital based in London. He's very skilled in minimally invasive endoscopic surgery and very involved with the British Society of Gyno-Endoscopy, BSGE. So Fevzi, let me hand over to you now to take us on from here. Thank you.
Thank you very much, Anne, for the kind introduction. Good evening, everyone. Welcome to this webinar. I'd also like to just start by thanking Medtronic for the organisation of the event, and please feel free to ask any questions in the chat as the talks go on. So I'll be talking about what family doctors can do for endometriosis, and in particular talking a bit about the diagnosis, a little bit on touching on the delay of diagnosis and misdiagnosis that we all know can sometimes occur, the management options, of which there are quite a lot that can be started in primary care, and then obviously my colleagues will talk about some of the more specialist aspects of treatment and management that can occur in hospital. And first of all, just want to start on really by the symptoms, which we all know there can be a whole variety and spectrum of symptoms, and we know that it can affect patients in different ways. We see that some patients have very severe disease, but very minimal symptoms. And some patients have very minimal disease and quite severe symptoms. But the common themes that we see with endometriosis are those patients that have a recurrent pain that can last even outside of a period, that can be on most days. Some patients, however, have symptoms which are limited mainly to their period, and that can also be associated with severe back pain. Some can have radiation of their pain down their legs or inner thighs. They can have very severe menstrual cramps and painful bowel movements, as well as other issues such as difficulty and pain when passing urine. It can be associated with heavy bleeding also, but not necessarily directly. And of course, if the endometriosis is at the back of the cervix or in the pouch of Douglas, we commonly see patients have pain with intercourse, but it doesn't have to necessarily be in those areas as well. And of course, the other big area where patients may present to you is if they're having difficulty trying to conceive. That may be the initial presentation as well. So those are the common themes that we see, but also we're seeing more and more rare types of symptoms which can present. Now, diagnostic delay is something that's been talked about for many years. We know that from our own studies as well, that patients visit healthcare professionals on average several times before they reach a diagnosis. And when patients have deep disease, it can take up to 10 years to reach diagnosis, more so than when it's superficial. We know that the healthcare professional to diagnosis time can be almost 6 years. And the problem is patients present to GPs later as well. A lot of these symptoms are disregarded by patients themselves or families, or historically regarded as not being so significant. So they present to GPs and to primary care and family doctors a lot later than expected. Now, this was in our own study where we published this information and had about 200 patients that we looked at. And about 75% had severe menstrual cramps in their adolescence. And interestingly, up to 83% were told that the pain was normal. So again, it explains why these patients are presenting later and later. And 51% of the patients felt that their pain wasn't taken seriously. This is quite similar to a lot of the data coming out from the US and also from Europe as well. So we're consistent in the UK with regards to that. And one thing that Anne also touched on, which is very pertinent, is that endometriosis presents like many other symptoms. And this was from the same group of patients that we surveyed. And we know that IBS is the most commonly misdiagnosed condition when in actual fact patients have endometriosis. But we know that IBS is a diagnosis of exclusion, hence, why endometriosis must always be considered. But the other aspects where patients were told they had other conditions such as PID, unexplained infertility, depression, stress, chronic appendicitis, and you can see the whole plethora of different possible diagnoses that patients are given. But endometriosis must always be considered. We know from the media that there's lots of coverage of endometriosis, especially in this month, which is Endometriosis Awareness Month. And it's gaining more and more traction, which is good for our patients, that there is greater awareness and better understanding. This was a study that we published in our hospital looking at the impact that COVID-19 had on endometriosis patients. So this was the largest data set in the UK. At the time, we surveyed 1,089 patients, and we looked at the different levels of symptoms that they had and whether COVID-19 had an impact on their symptoms or not. But what was very striking, and something we do know, is that depression, anxiety, and mental health was significantly affected in this group of patients. They felt that their symptoms, 70% felt that their symptoms were worsened as a result of this. And even if they had COVID, some of them thought their symptoms had got worse. So mental health was one aspect that we picked up in this study that was adversely affected. The other was, of course, waiting times for surgery. Of the group, 479 of those 1,089 were planned for elective surgery, and only 83 actually got their surgery during the pandemic. Almost 400 were still waiting for surgery. And at the time of publishing, 52% did not have a new date for surgery. So it really shows the impact the pandemic has had on these patients. So when considering initial investigations for these patients, we know that one of the most powerful tools is your history and examination, going back to those initial symptoms, where those can actually highlight that this patient may have endometriosis. For us and my colleagues as gynecologists who specialize in endometriosis, pelvic examination helps us a lot, and we can combine that with a history and most of the time identify endometriosis when it's there, but imaging does significantly help how we plan our management options. So ultrasound is useful, yes, and it's good for things like this on the screen where you can see an obvious endometrioma, which has that homogeneous appearance and some peripheral rim of normal ovarian tissue. And when you have an endometrioma, it's likely you're going to have endometriosis elsewhere in the pelvis. MRI is also useful for similarly detecting endometriomas, but also other nodules of endometriosis, and particularly quite good at looking at bowel endometriosis, and again, helping us to decide what type of treatment is best for the patient. But of course, laparoscopy is the gold standard in terms of diagnosing and confirming endometriosis, because we know that it is a histological diagnosis, and that's currently the gold standard. However, there is non-invasive testing which is becoming available, in particular blood or saliva tests, which will be something that is available in some sectors right now, and in some countries right now will become more readily available as time goes on. So if you suspect endometriosis, what's the best way of managing it, particularly in primary care? Yes, a referral will be useful, but there are certain things that can be done even from primary care from the outset. So we know that certain aspects like physiotherapy, good diet, exercise help patients in terms of their general mental health, their well-being, and help them to manage pain. We know that some may require psychology or psychiatric services, which again can complement their therapies. However, when going back to basic analgesia, TENS machines has some benefit in terms of improving symptoms, quite readily available, fairly cheap for patients to acquire, and can help some patients on top of all the other therapies available. Of course, paracetamol, non-steroidals, if patients don't have allergies, are basic medicines that we can all consider, and as well as opiates in some. Once we go into hormonal treatments, again, there's a whole range that we have available to us. So we have the combined pills, the progesterones, the intrauterine systems, and as well as the gonadotropin analogues. Now, with the combined pills, they can help with some symptoms of endometriosis. Some patients find it useful if they have heavy periods, for instance, but they tend to help only if taken back to back, for example, every few months, so that they have lower frequency of periods, for example. But of all the hormonal treatments, they're probably the least effective in terms of what the literature suggests, in terms of improving their symptoms. And it doesn't actually remove the endometriosis. We've got to remember that it only really tries to help their symptoms. Progesterones are effective at reducing pain and stopping periods in some. However, they do have some side effects which are troublesome to some patients, such as irregular bleeding, weight gain, acne, and can adversely affect mental health in some patients. Now, initially, a lot of the trials looked at Mirena coils with endometriosis, and it is effective for some patients, again, and quite useful for adenomyosis. There are actually about 6 different coils on the market now with different levels of hormone. Some have lower amounts which last for 3 years, and some last 5 years. But the only ones which have any studies or science behind them in terms of improving symptoms of endometriosis is the Mirena coil, but I'm sure some of the others will also have benefit. They just haven't got trials to support them. It's not useful in everyone. We know that some have cramps and some have irregular bleeding. And of course, then there are the GnRH analogues or newer antagonists, which are becoming available. And these are monthly injections, nasal sprays, and different preparations as well. These are some that I personally may use prior to complex surgery. Not everyone uses them, but they're not a long-term solution, I would say, for most patients. In some selected cases, they may be, but it's just useful to be aware that they do have some side effects. They are very effective, obviously, because you're switching off the ovarian axis so that patients' endometriosis are not fueled or symptoms worsen, but the low estrogen, the change in mood, and in particular the bone density loss is the most worrying symptom. So used for a short period, osteopenia is reversible, but obviously osteoporosis is not. So we don't want to get to that stage. So it is something to be used in select cases only. Now, NICE released a document in 2017. It was the first document for endometriosis diagnosis and management, and is currently being reviewed, and a new document will be released shortly. But it is quite useful in terms of, again, highlighting some of the first presentation symptoms that you may expect to see in primary care, how you can manage the initial presentation in terms of monitoring of symptoms and trialing basic analgesia. And really, if the basic analgesia doesn't work effectively, or fertility is an issue or a priority for the patient, then early referral is something that should be considered. So it's a nice algorithm that just guides you through a referral pathway and what can be tried and considered in the first instance. Really just summarizing a lot of what I've said before. So really, in summary, endometriosis we know is notoriously difficult to diagnose because it presents very similarly to other conditions and has a variety and spectrum of presentations. Because of that, unfortunately, it's got this significant delay that we're all trying to reduce as much as possible. I think if there is a strong suspicion, it's really important that referral is made early, especially with the long waits, not only to see a specialist, but also to have treatment. And we need to do this really to help our patients and stop progression of their symptoms, and really to monitor their mental health and stop that adversely being affected also. It's important that we consider this holistic approach with all the different therapies and treatment options that we have available. And like I said, a lot can be started in primary care before they come to see myself and my colleagues who specialize in endometriosis. And that can really help patients whilst waiting. And that's it. Thank you very much. I think we'll be having questions at the end, but thank you for listening.
Great, thank you very much. It's a great introduction to the different treatment options that are available. And I noticed people are putting questions in the chat. We are going to do the questions at the end once we've heard all three of the speakers. So thank you. That's a great start. Now, our next speaker is Karolina Afors. Karolina is working at the Whittington Health at the Portland Hospital, again in London. Big interest in research into endometriosis, as well as delivering the very specialist surgery that she does. And Karolina is going to talk to us about general pelvic pain management, which is so important for us in primary care. So I'll hand over to you. Thank you, Karolina.
Hi, thank you hello everyone, and thank you very much. I've tried to make this talk as practical as possible for GPs, so trying to put myself in your footsteps sometimes. So I'm hoping, obviously, if there's any questions, happy to take it, but trying to make it practical. These are my disclosures in terms of who I've been involved with. And my interest in pelvic pain is, unfortunately, it is a chronic condition affecting girls from very young now. And I'm certainly seeing a lot of younger patients that have been developing endometriosis, and it's essentially chronic pain that lasts for 6 months, and it's incredibly common, and it affects women worldwide. We know that the most common cause of pelvic pain is endometriosis, and we know that it does substantially reduce quality of life. It affects relationships. I always ask, I learned from a colleague, does it affect your work, rest, or play? It's not a Mars advert, but it's that idea that it does affect working. For example, we've seen that in the workplace, and there has been some interesting government initiatives on that as well. And the problem is that in the vast majority of patients, they may end up having a negative laparoscopy, but these patients shouldn't be ignored. And in fact, they're often the ones with superficial disease tend to respond not very well to surgery, and these are the ones that are often more challenging, in my opinion, to treat. I think when we're talking about pelvic pain, the important thing to also understand is that there does tend to be a big overlap between different specialties. And you've got different pain syndromes, and often patients with endometriosis might have more than one pain syndrome. So to name but a few, so if you look at chronic UTIs or bladder pain syndromes, I've often found patients where they talk about this stabbing pain near their urethra, one patient described it as pouring acid inside their stomach. And you can imagine these stories, they're really visceral. You feel almost the way they describe the pain, and they often coexist. It may be that endometriosis was the trigger, but I guess this slide is just to be aware, and you as GPs are probably far more aware of these other overlapping conditions. And because of how the nerves and how we diagnose different conditions, it actually makes it a real challenge because of the overlap. And obviously endometriosis being up here. And during this talk, what I'm going to talk about is endometriosis, but also vulval pain syndromes, because I think that these are often overlooked and we're not very good at managing them. So how do we get pelvic pain and how is it experienced? Well, we get it largely from end organs. So that's from the pelvis or the lower abdomen, but you also get central sensitization of the nervous system. And then you also get a musculoskeletal response to pain. So what do I mean by that? Well, if you're in pain, you tend to lean over, you tend to have a funny posture, and that can then put strain on other body parts. And there's obviously this huge impact. If you're in constant pain, it's really going to have an impact on your mental health, on your ability to carry out daily activities of life. And what's really interesting is that pelvic pain can be, you can have an inflammatory, you can have a nociceptive, that means, a specific target point of pain, or you can have a mixture. And we do know that women, both with and without endometriosis, they do have this hyperalgesia, so at non-pelvic sites. And this has also been shown with increased evidence in nerve fibers, which we've seen in endometriosis. But also you get decreasing grey matter volume associated with pain processing. And there might be an aspect to how women actually process pain. So you have an initial insult, such as endometriosis is the trigger, but then this can also affect your central nervous system and you get amplified or hyper analgesic responses to pain. And why this affects women more than men, it's just poorly understood. This is also what we see is that you get an overlapping of pain disorders. So you get a cluster of prevalent pain conditions that can occur together. So I'm sure often you've experienced women getting chronic migraines, tension headaches, fibromyalgia, temporomandibular disorders, low back pain, as well as endometriosis. And this affects predominantly women. And in fact, we see that these chronic overlapping pain disorders, the longer it takes to diagnose it, actually, the more likely you are to get the pain syndrome overlapping into something else. And women might get sometimes two coexisting at the same time, but it can increase to 3, 4. And it's this delay in diagnosis, which often leads to poor health outcomes because you get reduced quality of life, increased disability. And I think the problem is with endometriosis and also these pain disorders is that we work in silos, and as a result, there's not much joined up care between, let's say, urologist, endometriosis, gynecologist, gastroenterologist. So these patients are being seen by multiple different specialties, which makes it a further challenge to then bring it all together and to manage them most appropriately. Although these are figures from the States, this just gives you an idea of how much this costs the US economy. And, obviously we can extrapolate this to the UK economy. So it's a huge cost, these chronic pain syndromes. And if you think about it, also take it into context, endometriosis is as common as asthma or chronic back pain, yet the degree of funding when it comes to endometriosis is insignificant. It's less than 1% compared to what diabetic research gets funded. So it's really important to have a multi-system approach to managing pelvic pain. Fevzi's talked really nicely about hormonal treatment, which I'm not going to talk about. There's also other sort of nerve modulators or anticonvulsants that you can consider, but they've got their side effects. There's obviously surgery, which also can be useful, but I still think as a chronic condition, it's not necessarily curative. Physical therapy, incredibly important, mood disorders, exercise and diet, and also cognitive behavioral therapy. And also what I've seen actually is treatment for PTSD. So some patients may have had a real painful experience that is a triggering event for them. So sometimes using those forms of psychotherapy techniques can be even more beneficial than CBT. So I don't know, trying to just move this along, apologize. And it's about individualizing it for each patient, which again makes it, even more of a challenge because everybody's got time constraints. So we're talking about having this biopsychosocial approach, but also having shared decision-making. And what do I mean by that? Well, it's about benchmarking. So I think rather than saying that I can completely cure you, it's about coming to shared decision-making together and saying, well, What can we help improve? How can we help improve this? I'm not going to be able to get your pain from 10 to 0, but I should hopefully try and improve it in some way. And how do we go about doing that? Or identifying key symptoms that for that individual will really help improve their quality of life. And also having an integrative approach to pain. And what do I mean by that is by us as clinicians, working together across specialties for the sake of our patients to improve their quality of life. I know this is probably familiar to everybody, but the reason why I put this up here is that it's often not familiar to patients. So I often talk very simply to patients about, so how are you taking your pain medication? What are you taking? And you'll find that a lot of them actually will be sometimes taking just codidromol or dihydrocodeine because they haven't understood the analgesic pain ladder. And then they get constipated. Whereas if you take it back to them and explain that it's a stepwise approach, that you're adding one layer on top of another layer to help improve symptoms, and also asking them what dose they take. So the amount of patients that I've actually found that take 500 milligrams of paracetamol because they assume you're only meant to take one tablet in a packet. And I mean, this isn't rocket science, but it's about taking the time to take a really detailed history. Obviously, in those that can take ibuprofen, it's important to also talk about the right dose to be on. And if ibuprofen is not working, then to talk about non-steroidals like, let's say, naproxen, diclofenac. And just to have an understanding, the naproxen's got a shorter course of action, normally about 2 hours, which is good. But just to have an understanding of how these different treatment methods work together. The other thing I wanted to highlight is that women are twice as likely as men to have an adverse drug reaction. So we're more than 90% of women will experience worse side effects, and that's typically gastrointestinal side effects in relation to diclofenac. So often patients will stop taking their medication because of side effects, but we haven't asked them about their side effects. They don't always volunteer that information. So what I do encourage doctors to also consider is alternative methods of giving treatment. So I often prescribe women rectal diclofenac. They only need to take it once a day. And the reason being is that they have much less and fewer side effects. There is also an argument that it's more targeted to the pelvic area. So I think it's just a bit about thinking outside the box. And the reason why we have these side effects, we've seen in America now that the FDA has made caution about over 80 drugs now. And that's because women in studies, these historical studies, they were only included in research in the 1990s. So a lot of these pain studies have been around for some time, but they're based on male responses to treatments. So it's important to have an understanding of that. So benzodiazepines recently, or fairly recently now, it's about a year ago, the FDA advised that in women, the dose should be halved. And that's because women were suffering with road traffic accidents the following day. And that's because we have higher fat proportions in our body. So we were maintaining this in our cells for longer. And as a result, you were having this hangover effect for longer than our male counterparts. So again, it's about bringing it back to individualized treatment. I wanted to talk a little bit about antidepressants and anticonvulsants. So sometimes you might be looking at amitriptyline or venlafaxine, and these can be good for neuropathic pain. Unfortunately, they've just got awful side effects. So amitriptyline, you can slowly start up from 10 milligrams, but they've got constipation, dried mouth, blurred vision, and most of the time patients don't tolerate it to a level enough where they can get benefit. And also more recent studies have shown that actually it hasn't been a true benefit. Venlafaxine, there's not really much data. In fact, there's no data on chronic pelvic pain, but there has been some positive impact on quality of life in fibromyalgia. And it's still got side effects, of which it's sexual dysfunction and GI upset again. The other ones are gabapentin and pregabalin. And there was a big study done by Professor Andrew Horn, who's based in Edinburgh. This was published in the Lancet. I think it was about 3 years ago now. And in fact, there was no difference in terms of improvement in pelvic pain. And that's probably, again, because of the dose-limiting side effects with gabapentin. So if you can get them up to the right level, it may be of benefit, but they're never going to tolerate it. Interestingly, pregabalin has got slightly fewer side effects. I've seen some good response with pregabalin, but again, there's a lack of research and data into it. And also you can now, in the States, you can get like a pregabalin gel or cream, which can sometimes be used for more topical sort of vulvodynia type symptoms. So what I wanted to talk about, I know that Fevzi's talked about all the hormonal treatment. I just wanted to talk about vulvodynia and then talk about more alternative treatment therapies. So vulvodynia, or pain in the vaginal area, they almost always coexist at some point, I find, with endometriosis patients. They're typically the ones that get pain on intercourse. Although they get pain on deep intercourse, they eventually often get also symptoms of vulvodynia or vaginismus. There might be triggers. So this could be, sometimes you can experience it even with having acute infections, whether UTI or vaginal infections, a traumatic childbirth, or often sometimes it can happen, fortunately, following surgery. If they've had prolonged sitting, or if they've had muscle bracing because they've been in a lot of pain, or altered gait as a result of functional issues. And essentially, they often get, when you look at the vagina, it's really important to do careful examination, but they might get a local inflammation. So it's important to treat this. So this can sometimes be with topical steroids or an emollient cream. An emollient cream should be ideally a hydrophilic cream. You can also use sometimes like coconut products as well. Estrogen cream can be really good for promoting regeneration, and also antihistamines to prevent scratching. And it's also really important to treat antimicrobials for chronic vaginitis infections. So we know that BV and thrush can often recur. It affects a huge amount of patients. And you can also consider maintaining a normal acidic pH by taking 1 gram of vitamin C or boric acid suppositories. And that can help women as well who often suffer from recurrent infections, which can then lead to inflammation. In terms of neuropathic pain, so and again, this is all talking about more in the vaginal area, you can talk about taking gabapentin, amitriptyline, but my preference would be pregabalin. And also even just topical anesthetics, if they get a referred pain down to the vaginal area, sometimes just giving them lidocaine gel 2.5%, for example, might be adequate and might help them improve their symptoms. And then lastly, you can also talk about neural blocks. So sometimes that can be done with the pain clinic, where they can do sort of pudendal blocks. In terms of myalgia, physical therapy. So physios who've got a special interest in pelvic floor physio, it's important to understand how to contract the pelvic floor in women who are recovering from delivery of vaginal delivery or having had a baby, but equally to how to relax it. And also having a musculoskeletal approach as well, because often they might have posture issues from being in constant pain. Also using vaginal dilators or vibrators, where they can use this as their own trigger massaging to help with trigger point pain. And again, I've also used vaginal trigger point injections for some women who've had incredible pinpoint trigger point pain. I've seen this in a couple of cases where they've had a very traumatic delivery, post-forceps delivery, for example, and you give a local anesthetic injection of steroids and a local anesthetic agent. And then psychosocial is incredibly important. So treating underlying mood disorders, also being aware of CBT, things like mindfulness, stress control, and sleep. Sleep is incredibly important when it comes to patients' experience of pain, and also relationships. So there are some apps now out there, such as We Are Furly, which provides psychosexual therapy through an app device, which can be incredibly useful and cost effective because it's often difficult to get patients to a psychosexual therapy. And also using general anxiety scores. So general anxiety score, it's only like a 7-point question. It's incredibly quick to do in clinic. You can even just do it to a smaller 3-point score. And that can be quite useful just to see, is your therapy working? Is it helping them at all? And just be aware that anxiety or difficulties coping may be more common than depression. So they might not tick off all the symptom diary when it comes to depression, but be aware that these patients may still not be coping and need added help. So I wanted to, so when it comes to sleep disorders, it's really important that we ask people about sleep. So pain makes it difficult to sleep. Sleep problems can worsen your pain, mood. You can have low energy levels. It can also, again, affect your performance at work, your relationship with your children, your partner. And it can drain your energy, and it stops you doing what you normally do. So it's important to have a consistent sleep schedule, try and limit daytime naps, have a relaxing bedtime routine. And these are really, these are sort of, it's not rocket science, but it's about having a dialogue with patients about this. Equally, regular exercise can really help, in having a healthy diet, obviously avoiding stimulants such as caffeine and nicotine in the afternoon, not having too much fluid before bedtime, because otherwise you might be getting up at night. And also having downtime from phones that we're always walking around with. I think it's a good example to set for children as well. And also getting adequate, exposure to light, because you do get this sort of seasonal affective disorder, which I think we all suffer from a little bit. Equally with depression, stay connected with people. So people tend to withdraw when they're depressed, and it's often about, why have they withdrawn? Why are they becoming isolating? Taking regular exercise, there's been evidence that this reduces depression and stress, and it also improves sleep. Do things that you enjoy, boost your serotonin levels with sunlight if you can, and also challenge any negative thoughts if possible. CBT to address thoughts and have more of a coping mechanism. And also this exposure therapy. So a couple of patients I've had have really benefited from repeated exposure to these anxiety-producing situations, because they tend to develop a PTSD type syndrome. In terms of complementary therapies, I'm a big believer in doing this, particularly if patients get a benefit of this. They can do this alongside medical or surgical treatments. And in fact, although there's limited evidence, there is some evidence to support effectiveness of acupuncture for pelvic pain, especially when it comes to endometriosis. It's been shown to lower pain scores, and also it can be combined with conventional treatments. Also, there's this idea of administration of Chinese herbal medicine, which there was a study that showed it had comparable benefits to gestrinone. So these are really important things to have an open conversation with your patients about. In terms of dietary, so there is a growing evidence of diet publications that are coming out. So sometimes, we know that omega fish oils can be of benefit, having a diet that's high in fresh fruit and vegetables. I mean, essentially, this is leading a healthy lifestyle, but we do know that reducing red meats, particularly, there was some studies that showed that red meat and endometriosis, and that's important to identify. And also, it might lower I don't think it lowers your endometriosis risk, but it's got to do with estrogen excretion. And there's some small studies that can help with that. In terms of women who suffer with bloating, eliminating gluten may be of help. Taking peppermint tea can also be beneficial. And again, there is some objectivity of having a low FODMAP diet. Now, a low FODMAP diet is incredibly restrictive. And often these patients can be quite young. So I would say with all these diets, what I always say to everybody is that you can remove it for 2 weeks, assess if it's of any benefit. If it's not, reintroduce it and then assess again. And the idea being is that you don't want to, in women who've got a background of anxiety disorders, you then don't want to replace one problem with another, such as developing an eating disorder. I just wanted to touch upon cannabinoid products. So there's been a lot in the press about CBD. So CBD can help. There's been some evidence coming out that it's got from Imperial, actually. So Imperial are doing a wealth of research about cannabinoids, and CBD has showed some anti-inflammatory actions. It can also help with sleep in menopause patients. And it's also shown to be beneficial in endometriosis-related symptoms, reducing, for example, in those patients with chronic pain, their opioids requirements as well. There was a study that came out in 2020, which in a mouse model showed that THC, which is the part of cannabinoids that give you the more high effect, actually reduced endometrial growths. And I believe there's more studies going on into this at Imperial and also in Europe. There was also a study published by Sinclair in 2021, and this is from Canada, where they showed that there appeared to be a benefit in terms of pelvic pain, gastrointestinal and mood issues, and these were based on patient-reported outcome measures, and of course the reduced opioid requirements. So this might be something that nowadays is available only on prescription, privately. But this might change. And also CBD is available over the counter where patients can buy this. It's important that it's a full spectrum CBD. And we just need to be a little bit conscious about where you're getting the products on, because there's a wealth of it on the market. Lastly, I'm just going to touch upon digital health solutions. So there are several digital health providers looking at endometriosis: Bloomful, Friendo, Serona Health. I think there's a great need for these digital health therapeutics, because there's not enough of us sometimes, and it can certainly help with providing at-home support and also information to patients. What's important though is that it needs to be obviously evidence-based, so the key information needs to be delivered in the right way. It's important that these devices are registered as medical devices. An app can also be registered as a medical device, and also have CQC regulation for effective quality control and safety perspectives. But I think it allows patients to, for example, track symptoms. So you can track them, which I think can help with diagnosis potentially in the future. And again, can also provide dashboard for clinicians to have access to information about patients, so that you can together, you've got data to drive decision making and have shared experiences. And the shared experiences are through having communities of people with endometriosis. So in conclusion, it's important to have an individualized approach to women with pelvic pain. It should be tailored and managed in an MDT setting. We as clinicians should be really careful that we don't just act in silos. It's really important to have this understanding of the chronic overlapping pain disorders and how this adversely affects women, and also to adopt a holistic approach. So if complementary therapies can help, I think it's really important to embrace them, and this can be done alongside more conventional treatments, and to consider digital therapeutic solutions, because they're likely to be useful, cost effective, particularly for at-home solutions and support for patients. Thank you.
Great. Another fantastic talk. Thank you so much. You've really highlighted some of those issues that we have in primary care about trying to get the medicines built around the patient, and some of the complexities we have with so many of the medicines, with the side effect profile and the education and the compliance. But the other point that you've very well made is that problem for us in primary care becoming increasingly so about the siloed. You'll deal with this bit, and then they've got to come back to us, and then we've got to refer to there, and it just seems so often that the patient is left bouncing around the system with very long waits at the moment. So a real problem for a lot of patients. And thank you so much for covering vulvodynia as well, because that is something that, as you rightly point out, is not often taught to us in primary care. So great, thank you so much. Again, the questions are coming in, but we'll pick them up at the end. So keep putting your questions in. And our final expert speaker seems to have disappeared. So I'm hoping he's still on the call. I've lost his little logo.
Yeah, he's just restarting. He had a little problem. Maybe we can do some questions.
Okay, yeah. So thank you. Let's pick up a couple of these questions here. There's a couple. I'll just pick these up while you're still there then, Karolina. There's one about Botox in conjunction with other treatments for vulva and vaginal pain. Do you use Botox?
I don't. They're more typically used by urogynecologists, and there is some evidence that it can be of benefit in trigger pain. You just got to be careful with Botox, because obviously you could get, for example, if you're injecting it too close to the urinary retention and things like that. So you've just got to have a very good understanding and dosing regime. And there is actually a paucity of evidence and studies when it comes to Botox. There's been a lot of research done on Botox for urgency, where they do intra bladder Botox injections, but less so on with regards to pain.
Great. Okay, well, thank you very much. And I'll let you have a bit of a break just for a minute while Shaheen's back again now. So that's great. So thanks for that. So our final speaker, Shaheen Khazali, is another expert endometriosis surgeon based at the Lister Hospital, the London bit of the Lister, not the London bit, but we've just been discussing there's a Lister Hospital in Stevenage, but Shaheen works at the Lister Hospital there in London. And he's going to talk to us about some of the latest developments in endometriosis care. So welcome, Shaheen.
Thank you. Can you hear me all right? Okay. Sorry, my Zoom crashed for some reason. Thanks for the introduction, and I thank Medtronics for organizing this. There's been a lot of work has gone into this, and I think that's really great work and very good turnout. So thanks for the introduction. And what I'm going to talk about is a reflection on what changed in my practice in the last 5 years. I've been doing this for the last 12, 13 years. And when I looked at my own practice over the last 5 years, actually, I realized that a lot has changed. We are doing things slightly differently in many aspects of what we do. So I'm going to cover what's new. We'll talk about tests, imaging, new drugs. Some of what I'm going to say has been covered very nicely by Karolina and by Fevzi, so I will try not to repeat those. And then we'll talk about robotic surgery, neuropelviology, alcohol sclerotherapy, but I'll try not to bore you too much with things that may not be necessarily useful in general practice. So what's new in diagnosis, and what are the things that you as GPs would find useful when it comes to diagnosis? I think one thing that was covered is how social media and the information age has changed what your patients will come to you with. So I think it's very, very useful to know what they are reading and what the patients have heard in the media. Lots of information has been available now, most of it very useful, as Fevzi just said. But from time to time, we get very influential people and, if you like, celebrities who may not necessarily be helpful in the narrative. So there was a story not that long ago in the media about a celebrity who admitted herself in the hospital and said, until you do a hysterectomy for me, I'm not going home because I have endometriosis. And then we had lots of patients who then believed that endometriosis has a cure, and the cure is a hysterectomy, which of course is not correct, and I will cover that. So it's important to remember that social media is like a double-edged sword. It does really help in raising awareness, and in fact, there was a recent study coming out of Canada, and they showed that most of the information available on the support groups on Facebook and other social media do have useful information. So perhaps being very having a negative approach towards them is probably not the right approach. A lot of those are helpful, but as GPs, I think it's really good if you can take the time and have a read of what these patients are reading. That could be very helpful. So I will go straight into this because some of it I'm going to cover, that some of the myths are coming from those social media websites, but actually a lot of facts also are included in those. Hysterectomy is the cure is my favorite one. That, you know, by definition, as you heard, endometriosis is the growth of endometrial type tissue outside the uterus, and therefore it makes absolutely no sense to do a hysterectomy to cure endometriosis. Of course, the caveat is when you have adenomyosis, that's when same tissue grows inside the muscle of the uterus. That's a different story. Also, I think it's good for us to be a bit reassuring because, of course, it's very important to raise awareness, but there is a balance. Sometimes raising awareness causes anxiety unnecessarily. For example, having endometriosis doesn't mean infertility. It means there may be a problem or an impact, negative impact on fertility, but that doesn't mean that if you have endometriosis, you're going to be infertile. I also don't like there is no cure for endometriosis narrative because, in fact, a lot of the time that we see patients coming back again and again could be due to incomplete treatment. So, continuing with the diagnosis, laparoscopy is no longer the diagnostic gold standard. What does that mean? Because that could also be a bit of an upsetting, if you like, statement. Lots of patients objected to that line that came out of the ESHRE guideline that came out last year. What they meant by that is that with the progress in imaging, nowadays we can in fact diagnose endometriosis in many patients. Of course, that still is going to be the case that with a negative ultrasound scan and even a negative MRI, you cannot rule out endometriosis and superficial endometriosis in somebody who's doing ultrasound scan in endometriosis as well as other areas is not going to be picked up. So laparoscopy is not always required to make a diagnosis, again, as Fevzi demonstrated. The other thing I would like to mention, again, this is something that came out last year and I was part of the writing group, is the worry about cancer and endometriosis. Again, it is true that women with endometriosis have a higher risk of ovarian cancer, particularly in those with endometriomas, and that can be up to double the risk. But we need to remember that the risk of ovarian cancer is generally very low, and therefore the absolute risk of ovarian cancer is still very low in patients with endometriosis. The bottom line is this would not be an indication for surgical treatment of endometriosis, but of course it's very important to be able to answer the patient's questions and worries about cancer with endometriosis. So what has happened in the last, say, 100 years with diagnosis of endometriosis? Well, history and physical examination has always been, in my opinion, the most important diagnostic tool. And then we had ultrasonography and MRI, and surgery from the 1960s onwards has been, if you like, the gold standard. Different ways of trying to predict the risk of endometriosis have been proposed in the last few years. There is a project going on in Europe at the moment called the Female Project that is aiming to predict the risk of endometriosis using questionnaires. But where are we now? You may have heard of blood tests for endometriosis or saliva tests for endometriosis, and that is something that I've been very interested in, particularly in the last year. And for that reason, we invited my good colleague Sofiane Bendifalla from France to come and give us a talk in our journal club in January this year. So this team in France have come up with a really clever test, saliva test, in fact, and they claim specificity of 100% and sensitivity of 96%. In fact, I was made aware just a couple of weeks ago that this is now available in the UK. Where do I stand with this? I've seen the study, I've spoken to Dr. Bendifalla, and I honestly think that we need more information to be able to routinely use This test, the study looked at 200 women in France, and I think that before I would start using the test routinely, I would like to see some more information and some more evidence. But I'm cautiously optimistic that this or similar tests will eventually be able to help us reduce that completely unacceptable gap. What else? Well, we can use technology to help patients understand their anatomy, or help us understand the anatomy by doing a 3D visualization of the anatomy. So this is a documentary I recently took part in for the BBC, and you can see how beautifully we can show the patients using the virtual reality visors of exactly what it is like inside their body, what surgery we are going to do, why, and how that would affect them. So this is still not available for general use, but I can imagine that in the next few years that could become something that we can use. So that's diagnosis. What about treatments? Again, this was covered, and in fact, Karolina covered quite a lot of this, and I learned a lot from listening to that. I will only mention one drug because that has become available in the UK in February 2020. It's been around for many years in Europe under Visan, but I find Dynagest quite a useful drug. I use it normally as a second line after the progesterone-only pills or the combined pills have failed. And my philosophy is that if medical treatment is appropriate, acceptable, tolerable, and controls the patient's symptoms, then that's fine, because we should remember that we are treating the patient, not the disease. The aim of treatment is to give our patient quality of life that she has been lacking back. And therefore, the aim of treatment of endometriosis is not necessarily to eliminate the disease, which is only achievable by excision of endometriosis. In many cases, that is necessary because the medical treatments have failed or is not appropriate or acceptable to the patient. But Dynagest also comes with a list of side effects, and they are not the same as the progesterone-only pill, and it is not possible to predict which of these side effects our patients are going to experience. But generally speaking, my personal experience is that it's tolerated well. Not all GP surgeries in the UK have access to it, though, which I think is something that is improving up and down the country. But I believe that is a really good tool to have in your toolbox. And surgery. So there were a few questions in the Q&A section about surgery, and I hope I'll be able to cover that. Yes, there is a role for surgery, and if done well, surgery could actually be quite effective. What's new in surgery? Well, I think I would start with just reminding us that endometriosis is often a lot deeper than we think. So when 40, 50 years ago, we were starting to understand endometriosis, we were just describing it as adhesions or spots or lesions. And the laser was very sexy at the time, and therefore we learned how to laser the endometriosis away. But now we know that in most cases, it's been suggested up to 80%. Even peritoneal endometriosis is actually a bit deeper than we think. And that's why we call it an iceberg endometriosis, or we say that what we see is just the tip of the iceberg. And that should make sense, therefore, that just by lasering away the tip of that iceberg or applying a bit of diathermy, we are leaving what's underneath the surface behind. So what we call a recurrence of endometriosis may in fact be as a result of incomplete treatment, not the true recurrence. And therefore, that's my motto, that excising endometriosis is the way to go. So if surgery becomes necessary, then there is general consensus that excising endometriosis, particularly deep endometriosis, is the way it needs to be done. In my opinion, the biggest advance in surgical management of endometriosis is not new equipment, is not new cameras, is not the robot, is not fancy, even surgical skills. I think it is the way we work together and the way that we have realized now as a community of endometriosis specialists that the way to go is to work together and to centralize endometriosis care. And I think we should be proud that in the UK we were one of the first, if not the first country in the world that did that properly and formally. Early 90s was the time that this was done. And the idea was, we know endometriosis is a complex condition, and therefore it really matters how the surgery is done and where the surgery is done. The volume of work is extremely important. It's obvious that if you do a lot of something, you'll get better at it. And of course, it's also true that you do need the right team around you. You need a specialist endometriosis nurse to work with you. You need to be able to train the next generation of endometriosis surgeons, and you need to be able to do proper research. And all of that would only be possible if you have the right volume. So in the UK, the British Society of Gynae Endoscopy has centralized endometriosis care, and therefore there are now accredited endometriosis centers up and down the country, and you can go to bsg.org.uk to find your nearest endometriosis center. And these were the numbers from a couple of years ago. So what are the new advances in surgery when we do end up doing surgery? I'm just going to show you a couple of videos of examples of patients where we had to work in a multidisciplinary team. And that now the range of that is expanding, at least in my practice. So this was from a couple of weeks ago in a patient with diaphragmatic and pericardial endometriosis. This is an endometriotic lesion over the pericardium, and we are using the robot with the thoracic surgeon. I wouldn't dare doing that part of the procedure, but you can see that we are excising the endometriotic nodule from the pericardium, and then we continue working on the diaphragm. We are opening the diaphragm. You can see the lung, and you can clearly see the deep and very painful endometriotic lesion inside the chest cavity. And in the same patient, we also did a VATS procedure. So we went from the chest downwards, as there was some more disease in the on the pleura, which needed to be excised. We have to remember, though, particularly as most of our audience is general practitioners, that these are rare. You know, these do happen, but not all chest pains are diaphragmatic endometriosis. In fact, 93% of patients who report chest pain with their menstruation, or even with those with endometriosis, don't have diaphragmatic endometriosis. So that's very important to remember. Another example is a lady who lost the function of a kidney completely. So that's an international patient. who had completely lost the function of one kidney, and we are joining forces with the urologist, and we have removed the left kidney at the same time as part of the bladder and the whole of the ureter unblocked. The same patient also had a bowel nodule and needed the colorectal surgeons to remove part of the bowel. So the three teams working together on the same patient to remove endometriosis. This one is showing how we are now being very careful when working around pelvic nerves. And this is the small pelvic nerves. This is the hypogastric nerve. And we're trying to preserve this, even though the disease seems to be going into the nerve. But now we understand and we realize, thanks to a new discipline in medicine called neuropelviology, that these nerves do matter. They are there for a reason, and things that maybe 10, 15, 20 years ago were not seen as important structures in the pelvis are now seen to be very important, and therefore we do everything we can to preserve these structures. And finally, this is a demonstration of how deep endometriosis can go, even though it may seem superficial. And this is a lady with sciatic nerve endometriosis, again from last month. And you can see here chocolate material coming out of the sciatic nerve on the right side. And she had a foot drop and extreme pain, which was cyclical. So if you have a patient, young woman who has cyclical sciatica, maybe endometriosis could be a cause. Again, I repeat that this is rare. So most sciatica is not endometriosis. So my last slide is another, in my opinion, advance in endometriosis surgery. One problem that we have with endometriomas is that if you apply the same principle to the chocolate cysts or endometriomas, that, okay, all endometriosis has to be excised, then you are going to lose some good ovarian tissue and therefore reduce the patient's ovarian reserve. And remember, when I was saying that we're treating the patient, not the disease. So the aim of the treatment is to address what that patient's wishes and preferences are. My patients won't be happy with me if I eradicate all her endometriosis and then render her menopausal in the process. So one challenge we've always had was how to treat endometriomas so that they don't come back immediately after surgery. And a new technique that we've been using is called alcohol sclerotherapy. And the idea is that instead of excising the inside of the endometrioma, we make a little hole in the endometrioma wall. We wash it out, and you will see here what an endometrioma looks like. You will see the brown material coming out. So that is oxidized old blood that is sitting inside the endometrioma. Then we just expand it a little bit, wash it out, and then insert a Foley's catheter and instill it with 96% ethanol and leave it for 15 minutes. And the initial data coming out of France and Italy is very encouraging, in fact, showing only 9% recurrence and a smaller drop in the anti-Mullerian hormone or the ovarian reserve. And that is me. Thank you very much for listening.
Great, thank you very much. And such complicated surgery. You can see why it's so, you'll be so careful, haven't you, with those structures around. I'm always impressed with endometriotic surgeons and know why I definitely didn't do gynecology as a surgical specialty. So our last bit, lots of questions still in. I think we're answering some of them because I know we're going to run out of time. But we've got a couple of cases. Fevzi, do you want to do your cases so that we'll hear how you put it into practice?
Thanks, Anne. Again, I won't be too long with this, but just to highlight and summarize some of what we've discussed, and in particular what Karolina and Shaheen have said as well. But I just want to talk briefly about ureteric endometriosis. And I know that Shaheen did mention that and some of the consequences of it, but it's certainly something that I'm seeing a lot more of in my personal practice, and I'm sure my colleagues are as well. But with ureteric endometriosis, yes, whilst we have to consider the patient's symptoms and focus on that, we know that it can affect 0.4% of genitourinary endometriosis. And we know that the extrinsic disease, so that's the disease that's actually compressing the ureter from the outside, is 4 times more likely than endometriosis that you may see in the actual ureter itself. And we know it commonly presents with bowel disease. But the issues that we've found and faced is that if left untreated, patients can present with renal failure in one or sometimes both kidneys if very, very severe. And this is something I'm certainly seeing a lot more of myself. Let me just. So one of the things that I'm noticing, just going to really much. In my own practice is a particular patient, and I'm seeing a lot more of this now, which in this case was a 31-year-old. She presented with really severe, painful periods for a number of years before she sought further help. But she was in fact going to A&E several times, presented at least 7 times to the accident emergency with severe pain, but again had a scan, quite normal, and then discharged home. But what's interesting on the imaging that you can see, and she, this is something that I ordered once I'd seen the MRI, which I requested. You can see this right side parenchyma of the kidney severely reduced compared to the left side. And you can see that this has been there because of a compression of endometriosis, physically causing back pressure onto the kidney and causing renal parenchymal damage. And that's something that we're seeing a lot more of. So doing something like a CT scan or MRI scan to look for this is something I'm doing a lot more in my practice if I strongly suspect or a patient has severe disease. In this case, a ureteric nodule had to be excised, and thankfully she didn't need to have a nephrectomy. She still had reasonable function in this kidney and was subsequently pain-free. This second case, again, is a very similar case whereby the patient presented with rectovaginal endometriosis and a full thickness bladder nodule. And she'd actually been sent to our unit really to have a nephrectomy at the same time because her kidney only had 6% function on that side. And again, you can see that when the case was started, you can see the ureteric orifice, and you can see partially the full thickness nodule coming through. It's a bit more reduced now because of some of the GnRH analogs she was on. And when you look inside on the left-hand side, it doesn't look too severe. However, on the right side, there is a large nodule which is compressing the ureter on that side. And you'll be able to see that's just the left side and how we do some of the dissection, which Shaheen has really nicely shown already. And on the right-hand side is where it gets a lot more tricky, where there is this ureter here, and it's going into a large nodule, which will become apparent shortly on this right-hand side. And then that nodule goes all the way into the bladder, which you'll see shortly. So once we're taking out one part of the nodule, again, it's something we do in a multidisciplinary team. And you'll be able to see this is going into the bladder, and you'll be able to see the methylene blue being released shortly as we excise that tissue. And there you can see, so here you can see the ureter going all the way into the insertion point of the bladder. And then this disease, which was on both the lateral and medial sides. And then once that's released, you can see into the bladder. And we obviously suture the bladder back. And she didn't need a nephrectomy in this case. The urologist felt that it wasn't necessary. She still had some function on that side. And she did quite well after this in terms of improvement in her symptoms. But it just goes to show that it is something we see more and more of, and something we must consider, because in these cases, any medical therapy, unfortunately, wouldn't resolve that disease. And they would need intervention to stop any permanent renal damage. And it's something that may also be necessary with patients who have severe bowel involvement, where they can get stricturing of their bowel, and can sometimes have bowel obstruction. So that was just really to highlight ureteric endometriosis and some of what we're seeing a lot more of now. So really, it's just to summarize in terms of, this type of endometriosis can be challenging to treat, as well as all the other complex ones, such as the diaphragm, that we're seeing a lot more of. And again, there's more and more awareness of these also. With these cases, we do need to act quickly, obviously, to stop long-term renal damage. And I'm sure, talking to my colleagues is something we're seeing a lot more of. An appropriate surgical plan and preoperative imaging is important in these cases. And of course, it's really important to, prevent this from happening rather than to try and cure it and deal with the consequences afterwards. But thank you very much all for your attention.
Great. Well, thank you very much. So we've got some questions that I'll just put out at random there, if that's okay. I'll take the first one because I know the answer to this. Maybe endometriosis should be taught in sexual health lessons in school. And the answer is it is meant to be on the curriculum. So in the UK, we've got mandated PHSE in schools, which includes a lot more about period problems. Endometriosis is one of those topics that's meant to be covered. There's just been a report out saying that it isn't as well covered, or generally they're not working, the lessons aren't working quite as well as they could do. So there's a lot of work to be done around those. But I agree with your comment. And the answer is yes, it is about raising awareness, getting people to seek help earlier. Okay, so Fevzi, while you're on my big screen there, someone's asking about delay in surgery leading to worse outcomes for fertility. So often, we might give the pill, it might solve some of the pain-related problems, but are we compromising her fertility in that way?
Well, I think what's reassuring, Anne, is that a lot of endometriosis patients are still able to have children and have no real huge impact or long-standing impact on fertility. We know that about 75-80% of patients are still able to conceive without, surgical intervention. But equally, we know that those patients which have difficulty conceiving and have symptoms of endometriosis, if we do provide surgical treatment in the form of excisional surgery, then there is known benefit in terms of improving pregnancy outcomes for patients. So again, it's something that needs to be individualized for that particular patient. But I think the messaging really is it's not a cause of infertility for all of these patients, and most will be absolutely fine getting pregnant.
Great. So just going on from that, I'll keep you on the spot here. If a trial of COCP, so trial of combined pill, improves pain, they got a normal scan. Is there anything, should we be referring in? Should we be doing more management or investigations like in primary care?
I think if you've excluded anything severe, I think in terms of history or with scan, as you mentioned, and patients are seeing an improvement, then I don't think there's any issue with continuing with that. I don't think they necessarily have to have multiple investigations. But yes, I would say that if there is any deviation from that, or patients don't see improvement, then referring along for further assessment and investigations is required.
Great. Okay, thank you very much. Right, Karolina, I've got a couple of questions for you, if that's okay. Somebody's asking, is there any evidence that keto, I think that must be keto diet, helps with symptoms of endometriosis?
No, not that I'm aware of. It could be helpful in those patients who also have polycystic ovarian syndrome, and if they've got an insulin resistance, which they often coexist, these conditions, but there's no evidence to my knowledge that keto helps with endometriosis.
Great. And the other question there for you is about NSAIDs. You talked about which one you prefer. Which is your preference?
At the moment, it's rectal diclofenac because it seems to work better. The patients, particularly those that have had side effects, or naproxen seems to work quite well as well, in my experience. But yeah, I think it's obviously if there's no other contraindications to taking NSAIDs.
Great. We have a bit of a problem with diclofenac in primary care, so I think probably for us it would need to be naproxen first, I think. And if period pain, well, I've got you. If period pain due to endometriosis does not settle with paracetamol, NSAIDs, or mild opioid, can we prescribe back-to-back pills in 13 to 14-year-olds?
Yes, I think it's reasonable if you've spoken to them, if they've I think getting family members involved and making it as a shared decision making. I think it's also quite a useful way to help potentially make a diagnosis. I also think it should be investigated with an ultrasound scan, just to you can still do a pelvic ultrasound scan with a full bladder that allows you to see all the pelvic organs. So I think that would be helpful to investigate there's not something else causing the pain. And if there was an improvement with the pill, it might help to make your diagnosis as well. So I don't think there's a problem with it, but obviously it needs to be done with parental involvement and being comfortable and explaining what it is. But there are lots of younger girls now taking contraceptive pills for medical reasons, not obviously for contraceptive reasons.
Yeah, I fully support that. So great, thank you. And we talked about the 3 months lot. If you look at the faculty guidance, the Faculty of Sexual and Reproductive Health guidance, we can use pills for longer than 3 months. You can use it for 6 months or 9 months or however longer periods. And we've got if so us in primary care, it's off license, but we've got expert guidance to do that. So that helps us. So Shaheen, I've got a couple of questions for you. You showed some filming about sciatic nerve endometriosis. Do you always have to manage that surgically, or other ways of doing that?
Yes, at the moment, we have no other way. When we're talking about sciatic nerve endometriosis, we're talking about invasion of the sciatic nerve with endometriosis, and that's thought to be a very invasive form of endometriosis that could eventually cause problems with mobility, and the pain in these patients are usually like having a toothache, like having your teeth being drilled, but on a daily basis. That's how they describe it. So yes, surgery unfortunately is the only way. But again, I want to repeat that a lot of patients with endometriosis have sciatica. Very small number of those have sciatic nerve endometriosis. We now know that endometriosis up to around 2 centimeters away from sciatic nerve can irritate the sciatic nerve enough to lead to sciatica. And a lot of patients who are referred to me with the suspicion of having endometriosis of the sciatic nerve will end up having endometriosis close to the sciatic nerve, not invading into.
Right. I thought that was a great picture you had of the understanding of like the iceberg effect now. obviously making surgery so much more complex.
That's right.
You talked again about specialist units for endometriosis.
Yes.
You know, if you're working in an area as a GP and we think someone's got endometriosis, is the recommendation that even for the first investigations, we should be looking for an endometriosis centre? Or can we routinely refer to our local hospital, expecting them to refer on to an endometriosis centre if they need more surgery? What would you recommend?
It's the latter. So the NICE guidelines, in fact, have a very clear recommendation on. There are 3 levels. There is the gynecology unit, and then there is the endometriosis center. So you, if there is a patient that you're investigating for pelvic pain, normally they should be sent to your local gynecology unit, and they should then refer on to an endometriosis center if further treatment for severe endometriosis requiring multidisciplinary input is needed.
So most local hospitals, you'll have a laparoscopic surgeon who can do the diagnostic and if it's sort of less severe surgery, you're suggesting that's fine.
Yeah, or at least that's the idea. The best case scenario is that in each local hospital there will be a lead, like the cancer organization. So if you have someone that is being investigated for cancer, they're usually referred to the local hospital. There is someone who can deal with investigations and even some types of cancer. The same applies to endometriosis, that there should be someone in each unit that leads the endometriosis service, even if they're not an endometriosis center, and they would then be able to recognize which patient needs referring on.
Great. Okay, thank you very much for that. Fevzi, can I just put you back on the stage? You were talking about the saliva and blood tests. I think it was you, Fevzi, who talked about that. And I think you said that they are currently in the UK, but I'm not sure that we can get them as primary care. Sorry, Shaheen, are you going to answer?
Do you want me? Yeah, it was me. So I know a bit about that. I believe you can actually, even patients can get the test themselves, but I hope I don't get in trouble with the company producing it for saying that. I'm not sure about this test yet. I believe that it's at a very early stage. I was surprised when I saw it being offered in the UK market. It's expensive, £850, I believe. It has a CE marking, but I have looked at the evidence and I've spoken to the people who've developed this. To me, I think before patients go out there and order it and then come to endometriosis surgeons with a positive test, I think we need a little bit more information. I'm sure it's going to be a very important development, but for me personally, I think we need a little bit more before we can recommend this routinely.
Yeah, I mean, it'd be nice for us in primary care to have a test that we can trust, but we have to get very clear how the results come.
Yeah. I should add that the people who've developed this, it's not just something out of nowhere. They are serious scientists and serious clinicians, and I'm sure they wouldn't have introduced it in the market if they weren't satisfied. But this was done in 200 patients in France. All of these patients had chronic pelvic pain, and then 70% of this 200 patients had endometriosis and 30% didn't. This is not a representative population. I would really want to see an independent re-study of a bigger population, international, and then I will be convinced then.
Right.
I think also it's a saliva test, and saliva test, my understanding is that they can be a bit unstable. So if you don't get it to the lab in time, etc., or processed effectively, it can impact on the results. So I think it just needs to have bigger numbers to validate it, really.
Great. Great, thank you. And while you're there, I'm just going to ask another couple of questions because we're really conscious of time. Somebody's writing about bowel. Any advice on diet, medications that help management of bowel symptoms in endometriosis? Karolina, I don't know if you...
Sure, yeah. So essentially, peppermint tea is very good to help with bowel and bloating, avoiding sugary processed foods because it often means that you get more peristalsis movement. Sometimes buscopan might help, but I think looking at, and you might often have triggers, so you might find that there's a specific trigger. Also, I would say there are a small proportion of patients that might be celiac disease and not know it. So that's just something to consider. And there's just a last question. So other systemic illnesses, there is this school of thought that potentially endometriosis is an autoimmune condition. So it can coexist with other conditions. And that's why sometimes you can get polycystic ovarian syndrome and other autoimmune conditions. So just to cover that, like thyroid disease, etc. But yes.
Right. And you made a really relevant point at the beginning of your talk, which is about women's health issues like endometriosis being so poorly researched. I think it was you that said it, but it's certainly so true, isn't it? If there's a condition that affects somewhere between 5 and 10% of the population, and there's so little research on it, it's such a sad state of affairs, isn't it? So it's good to see some more ideas coming, and hopefully we'll get more of an idea about how to manage things. So a great point made earlier. And the last question comes to Fevzi. Something about you were talking about the different treatments. Can we now get an oral GnRH analog in the UK? Do you know if that's? I mean, there is one for fibroids. Is anyone using it for endometriosis yet?
So there are some studies running on the same medication for endometriosis. But for fibroids, it is licensed. You're absolutely right, Anne. But it does have some add back within it. So it's not a true analog in that it completely blocks everything and then you have no additional hormonal support. There is some hormonal support that comes along with that medication. That's why it's licensed for 2 years in the context of fibroids. But again, it's important to understand how it will work for endometriosis before we can actually recommend that. But it can be acquired. It can be, of course, used off license, with that understanding, but not routinely at the moment. And there is no evidence for it at the moment that I'm aware of.
Great.
Just to add one thing, Dynagest is licensed for the treatment of endometriosis. And the studies show that it is as effective as GnRH agonists. So it also has some estrogen in it, so you don't get as many of the hypoestrogenic effects. But actually, when they compared it with GnRH agonists, it was as effective. So, and I think, it's going to be a bit of a game changer for GPs because it's actually licensed. It's the only licensed treatment for endometriosis. So it's not for everybody, and it does have side effects. So in my experience, first, they need to stick on it for at least 3 to 4 months. They sometimes get some gastric upset, a little bit of mood to start off with, but then it seems to get better. So I sort of ask people to give it a good try, and then it normally works quite well. But it's not licensed as a contraception. That's the only other thing to say.
Yeah, which does seem a bit odd, really, because I
don't understand how they get pregnant, but yes, it's not licensed as a contraception. So,
and as you say, it's got loads of safety data, hasn't it, from been used in Europe. So other European doctors on this call might be thinking, what on earth are you talking about? Of course it's great. But we've only just got it in the UK. So great. Okay. Well, listen, I'm really sorry we can't get down all these questions. I knew there'd be a lot because it's such an important subject and something that is just great to hear updates and hear from you three experts. So thanks so much for talking this evening. Thanks for joining us, and bye from all of us speakers, and thanks for listening.
Thanks very much. Thank you.
Thank you.
Bye.